let's go ahead and start on our information for today then. Let me just share with you what we plan to do. We're going to be teaching the comprehensive health assessment, and that is the goal for this particular week, is to let you concentrate entirely on figuring out how to go ahead about doing a comprehensive health assessment. So some information and some announcements first about how that will work logistically, and then we'll go diving into the information you need to know on how to do a good comprehensive health assessment. So the first thing that I want to remind you of, I sent you an email on this, is that for your practice time, which is either this afternoon or tomorrow afternoon, you need someone to practice on, because you will be at home and you need a partner to practice the skills on. And so what we'll be doing is that you will be viewing a section of the student video that you've uploaded, many of you've already looked at. And for example, you'll do the neurological assessment, and then you'll stop and do that part on your partner. Then you'll do the sensory section, and then you'll stop and do that part on your partner. And you can use your handout as you're doing your practice. Then once you have done it in sections, learning each section as you go along, then you're going to do it head to toe one more time. So the practice will involve doing the full assessment twice. And I will be available on chat to answer any questions you may have. So because this is a lab and is counted as clinical time, you are responsible to be at your lab for the full amount of time. And so what I want you to do when lab begins is to check in with me on chats on Canvas and sign in. And then as you're going through the process of practicing, as you run into questions, I'm going to be watching the chat feed closely. Go ahead and type me the question and I'll give you clarification on any questions you may have as you're practicing. Now this is an important pass-off. This is going to be worth 500 points. So that is a pretty significant number of learning activity points. And so we do want you to be well practiced for this. Now, if you had been able to be present in the lab here for the teaching of this lab, we would have given you practice using the ophthalmoscope, the otoscope, and the reflexes. Since you don't have those at home to practice with today, what we're going to do to help you learn those skills is that will be the only skill during your pass-off that the instructor will take a moment to give you instruction on. So be prepared, know when you're supposed to look in the person's eyes, when you're supposed to look in the person's ears. But the instructor will help you through the process of doing that, because they will realize that you didn't get a chance to use those instruments in your lab practice either today or tomorrow. So the good news about these lab pass-offs is, although it's a very big pass-off, people do very well on them. They come very well prepared. And the practicing in this manner really helps prepare people well to do well on their pass-off later this week. When you come for the pass-off itself, you must have it memorized. So you aren't going to be able to rely on the handout for the pass-off itself. So that's kind of the biggest challenge of the pass-off, is memorizing the whole thing. And then when you come, you will need to wear your uniform. It will be in the practice lab, and you'll be expected to wear your face mask and your face shield and gloves, because you're going to be live and will be in, in a smaller quarters there. So like you do all of your pass-offs. Also bring any taste, smells, a pen light, stethoscope, and a little paper cup to put water in. And you'll see as we go through why that is needed. One more thing that's very important to do is everybody needs to bring a bed sheet from home. That's how we're going to protect the mattresses in the lab, so that we don't have to clean them between pass-offs. So you're going to put your bed sheet down when you're the patient, and then when you are switching roles, you'll take up your bed sheet, your partner will put down theirs, and that's how we'll keep it all from being cross-contaminated. Does anybody have any questions specifically about the pass-off and the logistics of it? Of course, I'm going to teach you now how to be prepared for it. Nope, sounds good. All righty, so let's go ahead and delve right into the information that we want to cover today. And that is, as we said, going to be learning how to do the health assessment pass-off. So the big question that often students will have is, why do I have to learn this big health assessment? Because when we go in the hospital, what we typically do is a baseline assessment at the beginning of every shift, and that's pretty thorough. But there are a lot more things we can glean from a health assessment. So why do you think we need to learn the full health assessment? Why are we actually putting you through the scope of doing that when you're a beginning nurse and you're becoming a nurse generalist? Why are we having you learn a comprehensive health assessment this early in your nursing practice? Any ideas out there? Recognizing abnormalities. Practice makes perfect. Very good. To understand more in depth what we can look at for an assessment. And those are all great responses and really do help to explain why we need to do the full health assessment. So for example, how many of you intend to work in the ER or in another high acuity setting, an ICU? Just throw it in. Let me know if that's where your dream job is. Great. We've got a lot of people who want to do that. How many of you have an interest in doing OB as the place you would like to work? Great, got a few more that want to do that. How many of you want to do behavioral health? I hope I've convinced a few of you that would be a good idea. Got a couple, that's always good. So the point is that you could be working in any setting. And when you work in a given setting, you need to be able to pull upon the health assessment parts that will apply to the patient that you're actually in front of at that moment. So if you're working in an emergency room with somebody who has a spinal cord injury, well, then you need to know how to do the neurological tests associated with checking for a spinal cord injury. If you are working in OB, you may have to do reflexes to determine if they're having complications of their pregnancy. If you're working in behavioral mental health, you need to know the mental status exam and how to accomplish that with your patients. Patients with head injuries need the mental status exam question as well. So the point behind this is that you are going to take all of this information with you into your practice. But at the bedside, you will pick and choose from that tool chest that you have of all of this information. You will pick and choose the tests you need in that setting to do a thorough assessment on that patient. In addition, how many of you have noticed that when you're working, that sometimes the nurse doesn't do the assessment, but the doctor walks out of the room and the patient starts asking questions about what the doctor was doing? Have you encountered that? Suddenly you become the source of explaining. It happens all the time. It does. So sometimes we may not be personally doing that particular exam, but that since the doctor did it and now the patient family wants to know what's going on, we need to understand the exams in order to explain it to them accurately and appropriately and what they mean. So it's really actually a hallmark and very, very important that nurses have a full understanding of a comprehensive health assessment. You will never in your practice do this full comprehensive health assessment head to toe like we're doing it in this pass-off this week. But by learning it this way, you will know all the components that you would pull out pieces of as you are in practice at the bedside. And so that's why we're teaching all of it to you, because we can't predict where everybody's going to practice, and it changes over time. Some of you may want to do ER and then you get bored with it and you want to do something else, or any other setting that could be true as well. So it's very important for you to understand all of these skills, and you're going to find that you rely on these far more than you ever realized, and how much they come in handy far more than you realize. And after you learn that this week, I hope you'll start paying attention to your doctors and fellow nurses and nurse practitioners, and notice how much they do incorporate many of these skills we're teaching you. And now they'll make sense to you. You'll understand why they're doing it and what the meaning of it is when they do it. And sometimes you will be doing these things as well. Now, a little caveat I want to start with is, you've been in nursing long enough to know that there are many right ways of doing the same thing. So for example, when you're doing the bed bath, you've got to go clean to dirty, you've got to maintain privacy. There are some underlying basic principles that you never breach, but there can be flexibility, and you adjust your techniques based on the patient's mobility, based on their cultural preferences, based on a lot of different things. And so you individualize your care based on what the circumstances are in front of you. And that's the way it is with the major health assessment as we look through it today. There are many right ways of doing a full health assessment. The techniques that you are being shown on that video that was released to you are the techniques we're going to have you do in your pass-off. As I teach this today, I've incorporated quite a few little video clips showing you how to do these. Since we're not in person and I can't do it with you in the classroom personally, I've inserted these video clips so that you can see how these skills are done. And you will notice that sometimes the examiner in that skill does the same skill in a different way than the pass-off skill that was done on for you as part of your pass-off. Two right ways of doing the same thing. So don't let that throw you. And which way will you do it for your pass-off? Like the pass-off video, exactly. So we chose the right way that we're going to go with for this pass-off. But there are, of course, many right ways of doing things. And I want you to be aware of that and be able to recognize it. You should be able to see that the person is doing the same kind of test, but with just a little bit different technique, and that they're right too. And so as you go through in your practice, you may or may not choose the exact ones we chose for your pass-off. As you develop your practice, you may prefer some of the other methods and incorporate them. But being aware of all of them is very important, and being able to help you to do this well. Okay, so hopefully I've got you excited about learning the full health assessment and have convinced you that it's a good idea to learn the full health assessment. Okay, so let's start with the overall general view. Now I want you to if you have a mirror handy, sometimes your phones have an opposite view so you can see yourself. And I want you to take a look at yourself real quickly in a mirror or something that allows you to see your reflection. And I want you to just look at your general appearance and overview and tell me what you see about yourself. What are some things that you can see because you just took an overall look at yourself? What are some things that you notice? So yes, we've got somebody didn't get enough sleep here. Exactly. There's no makeup, tired eyes, feeling exhausted. Many of you had to work the weekend, didn't get a long break before we started this another marathon. And so this is really true. You can look at people and go and see how tired they are. You can see if their eyes are red and bloodshed, I'm not saying coming up with the right word, but that you're able to, yes, thank you, bloodshot. And that the person may be, they're grooming. As we look at the picture here in front of us, we see this young boy is dirty. He's wearing a lot of clothes. Is that because it's cold, or is he homeless and he's wearing everything he owns? One of the things we pay attention to is, does the dress match the weather? So if this child is dressed like this today in the middle of August heat waves, then that's something to pay attention to. Perhaps they're wearing all their clothes in order to secure keeping all of their clothes for a later time. What's their grooming like? What's their odor like? Often we pick up a lot of information on the patient's odor. And these are important things for us to understand. You know that when people go in ketoacidosis, they can have that fruity odor to their breath that indicates they're going into ketoacidosis. Sometimes on their breath, we can smell that they've been drinking, or other things that we can pick up. Or perhaps they have really poor dental hygiene. We can see that their teeth need help, or their breath really reinforces that they need help. From our substance abuse lecture, we knew that people with methamphetamine often have a meth mouth, where they have a lot of decay because they haven't had saliva. As part of that, taking that drug, they have really dry mouths, and over time that really creates dental hygiene problems. So there's actually a lot we pick up on just looking at the patient. And so that's what I want you to not miss. Sometimes we get really busy, and especially if we're in an inpatient setting and we know what the patient's diagnosis is and we know kind of what's going on, we fail to really go in and look at the patient carefully and just kind of do that general assessment and see what's going on with them. So the very first step is always a general appearance. Then we're going to go on to the neurological assessment. And we have decided, for the sake of this pass-off, to organize the pass-off in a head-to-toe manner, meaning we're going to start with the neurological system, and then we're going to go to the face and the neck and the heart and the lungs, move on down the body through the various systems. And so the neurological system is the most challenging system for you to learn because it has many of the tests that you have not already learned in your baseline assessment pass-off. The easiest way to memorize the neurological assessment is to realize that there are 4 parts. There's the mental status, cranial nerves, motor function, and sensory function. So keep those in mind because I'm going to keep quizzing you on those as the way of remembering the 4 parts of the neurological assessment. So the first part of the neurological assessment is a mental status exam. And as you know, there are many purposes for using a mental status exam. We used it with patients who had psychiatric problems. Remember, I did this when you came for Voices Lab. We did this as part of assessing people who have dementia. We do this when somebody has a head injury. So this is very highly used as an exam that can be to help us know what's going on neurologically with our patients. So the first thing we're going to pay attention to is their speech. Is it clear? Is it appropriate? Do they have appropriate clarity, or do they have slurred speech? They can't get their words out, which could indicate perhaps that they're having a stroke, or maybe they have some kind of substance on board. So lots of different things could explain it. Then there's orientation to person, place, and time. So that's a repeat of your baseline. You know how to check for orientation. And what is the 4th orientation that is sometimes checked for? So I have the 3 in front of you, but sometimes there's a 4th orientation. It's situation. Can you figure out what's going on and where you're at and why you're here? And people who are older, sometimes they get really confused when something happens, and it takes them a day or 2 to kind of have their mind clear, be able to figure things out again. Also remember that with person, it has 2 parts. Do you know who other people are, and do you know who you are? Patients with dementia, earlier in their stages of dementia, of course, this is moderate to later stages of dementia, but they stop recognizing people around them. You have been their caregiver every day for the last 2 years, and they can no longer remember who you are. They can't remember who their wife is, who their children are. So they lose orientation to others sooner than they lose orientation to self. That if you ask those same people, who are you, they can produce their name. It is a very late stage, and many of our patients with dementia die before they ever lose that knowledge of who they themselves are. So if you're doing orientation on a person with dementia, you have to make that distinction. They've lost orientation to others, but they have orientation to self. Memory. So we have our memory questions, and as you recall, you have to use the memory words that are on the form in front of you. The one we're having you use for this pass-off are apple, table, and penny. Now, each of you did a little bit of a test on your patients in the hospital last time where they had to memorize, I think it was 5 words, and they were preset words that you could choose from. It is important to use the preset words, not just to make up words off the top of your head, because they have been investigated to make sure that we don't create language problems for people with English as a second language. And also because when we come up with the words on our own, we often have hints in the room that help us remember. So for example, if I said light, brown, and glasses, well, you can see it. There's brown in my room, the lights are on, and I'm wearing glasses. And the patient would be able to see that as well. So that means there are cues in the room for recalling the words. We don't want cues in the room when we're doing a short-term memory test. So you do have to use the pre-established words that are given to you, and there are many choices, and they're on forms. So use those that are on the various forms. Emotional state, we're gathering that as we go along. Does the emotional state match what's going on? Is this person tearful and withdrawn? Is this person angry and shouting? Is this person incongruent, meaning they, again, they have a affect that's incongruent with what's going on? They claim to be terribly frightened and upset, and yet there's nothing going on. They're quietly alone in a room and nothing's happening. So we're looking for that congruency of their emotions as well. Judgment, two kinds of judgment questions, common sense and concrete. Does anybody remember from last semester what our common sense questions might be? There were many. Throw a couple out if you can remember them. Okay. Yeah, ball in the road. If there's a ball in the road and you're driving down the road, what do you do? And of course, hopefully the person common sense says stop and look for the child chasing after the ball. Any others you can think of there? Okay, what do you do if you see flashing lights behind you while you're driving? Exactly. Those are the common sense questions. And remember when you were doing the voices lab, some of you actually struggled a little bit with the common sense question, primarily because the voices were so loud you couldn't hear what was being asked. So it was hard to answer it correctly. And those are the kinds of things we're picking up on. And of course, our dementia patients, sadly enough, they really can't solve common sense problems anymore. And it's kind of heartbreaking to see this with people, but they really can't. They genuinely are trying and they can't come up with the correct answers to these common sense questions. Concrete versus abstract. What do I mean by a concrete question? What do I mean by that? And what is an abstract question? Just give me examples of those. Yeah. Do you have a cake and eat it too? Exactly. You can't have your cake and eat it too is actually how it is said. People in glass houses shouldn't throw stones. Yes, exactly. So those are the ones that we presented last semester. And remember we said that when you present a little proverb, you need to make sure that it makes sense to the person who is your audience. And age does play a role. Some of you look at me like, I don't know what you're talking about when I say a bird in the bush is worth, a bird in the hand is worth two in the bush. It's like, yeah, right. What are you talking about? And so sometimes it is a little bit generational and how much people have read in literature, because when you read a lot, you get exposed to a lot of these kinds of sayings. And so it's sometimes before you decide they can't think abstractly, you should consider some that might be more age appropriate that anybody might know. For example, most people would know, what does it mean to be between a rock and a hard place? Or you can't judge a book by its cover. For example, Disney's most recent Mary Poppins used that one. So many people in the younger generation may have been exposed to that particular one and have an understanding of what it means. What we wouldn't want the person to do is abstract or to answer in a concrete way, meaning they take it very literally. If you throw a stone, the glass will break. And so that's an important aspect of understanding. Can they think concretely or abstractly? About what age are you when you start to have the ability to learn to understand the abstract meaning of things? Because of course it's normal for children to have concrete thinking. They take everything literally. Grandma's, sleeping in the other room, and really what we mean is that grandma died. And children will not get that. If you say to them, grandma's sleeping and she's not going to wake up, that means to them that she's sleeping. They don't get that it means death. And so they don't have the ability to see things other than its concrete meaning. About what age do you think it is that we grow out of that and start having the ability to think abstractly? Doesn't look like anyone's remembering that one. It is around the age of 9. Now, of course, it's individual. Some do it a little bit earlier, some do it a little bit later, but average age is around 9 that we grow into that ability to think abstractly. You can tell when your children have done it because they start seeing your reasons for getting them to do things and they call you on it. Whereas before they took it at face value. And so you can't quite talk them into things like you did when they were younger because they're understanding where you're coming from better. Okay, calculations is the last one. Now, calculations is the most difficult form of concentration questions. So a concentration question is things like spelling the word world backwards or doing the days of the week backwards. And calculations is one type of concentration question. It's the most difficult one, so it's the one we're having you do in the pass-off. And so we're going to ask you in the pass-off to have the person calculate back from 100 by sevens. Do that for a minute as I'm kind of changing slides. See how well you can do on your series of sevens back from 100. I have to smile because sometimes when I do the pass-offs, people have really studied well to do the pass-offs, but they made sure they studied the count backwards by 7 from 100 as well to have that down, because that's easier for some people and not as easy for others. When you're having someone do a calculation question, they have to count backwards by 7 or by 13. It's never appropriate to ask them to do it by 2s or 5s. It has to be something that really makes them concentrate, because remember, this is the most difficult concentration question, and helps you see that they can do that. Okay, how'd you do? You guys got your 7s down? You're all ready for the pass-off this week? I can see you're practicing there. I'm in 93. I love it. Well, I'll give you something to practice while we're talking here. This is true. It can be very difficult to do. I have twin brothers that were part of studies at the university when they were younger, and they would have them do it back by 13. But both of them have a very strong math background, so they actually did not find that hard to do. So their history does play a role in how effective people are with calculations. If a person who is older but has other signs of dementia can do calculations well, that still has to be put in the big picture. It may have just simply be rote memory for them because they have done so much mathematics in their lifetime. So that brings us to the point with any assessment finding. The assessment finding in and of itself doesn't mean anything. You have to put it in the whole picture for the assessment finding to have meaning. And there are many things that can create the same finding. So this is just gathering information when we do assessments, putting it with their history, and then drawing potential differentiations about what the problem might be. Okay, so to yourself, I want you, without flipping back on your screen, tell me what the 4 parts of the neurological assessment are. Just to yourself real quickly, see if you can remember them. So first one was mental status, then cranial nerves, then motor, and then sensory system. So we just finished the mental status exam, and it was a review of something you were taught last semester. So kind of take heart in how the things that you see as review. Because as you're memorizing this, it seems like a lot of information, but in truth, you've learned over half of it already. Okay, so the next section is the cranial nerves. And the cranial nerves are very important tests that are often done as part of a complete neurological assessment to be able to determine what's going on both sensory and motor with the patient when we're trying to figure out a neurological problem that may exist. So to best demonstrate this, I'm going to go ahead and insert a cranial nerve video that I want us to view together. And I'm going to comment on it as we go along. And so let me get that up and we'll review our cranial nerves together. It's interesting that the olfactory is often something that when physicians do all the cranial nerves together, they often don't check the olfactory. That's okay, but when they document, they better claim they, if you didn't do all 12 cranial nerves, you better not say all 12 cranial nerves are intact. You have to say, 11 of the cranial nerves were intact and we didn't do olfactory. The interesting thing is that although this has routinely been skipped by lots of people, not so much anymore. Why do you think we don't skip it as much anymore as we did before? Yeah, it's the COVID, exactly. It's a sign and symptom of COVID. So it has just had an uptick in how often we do it again.
motor, trocar, and the patient's nerves, which control eye movement.
Okay, notice that the H shape is the same as the X shape that you are shown in the video that you've been watching. So you can see that there are, two outer points. There are one going across, and then there's the two upper outer points and the two lower outer points, and the one side to side. So these are just two ways of demonstrating the same thing, and either is an appropriate method to do. So you aren't being expected to do the saccade, so I just quickly went through that. So we'll pick back up now on the central nerve number 5. The corneal reflex is not required. Once again, follow the video we give you for what you include and what you do not include. So I've just skipped past some of the more involved hearing tests. Typically, as nurses, if we suspect a hearing loss that's not already been diagnosed, we would send them to the appropriate audiologist for further evaluation. So I'm skipping past those explanations for additional hearing tests and also for dizziness tests. You may have an interest in seeing them on your own. All of our in the PowerPoint, all of the YouTube videos that I'm showing are embedded in the PowerPoint. So all you need to do is look at them at your leisure, but they will not, these tests that I just skipped are not part of your pass. Okay, so you can see that there's a lot involved in the cranial nerves. In your PowerPoint, you have the chart that tells you what the cranial nerve is and how you test it, and whether the test is a motor test or whether it's a sensory test. During the pass-off, you will need to be able to name and number the cranial nerve, as well as demonstrate the test. And so this video is a good review of how to do some of these tests. And again, the video that was done for your lab is a great resource for what we expect to see. As you'll notice when you compare, there are some, they have done some of the tests in a little bit different way. Once again, more than one right way of doing things. So this is actually a good breaking point. So let's go ahead and take our 10-minute break until 9:45. And then we'll come back and do the third part of the neurological assessment. So right before we go, what are the 4 parts of the neurological assessment? So I hope you're thinking it to yourself. Amy's going to let us know here. A couple of you are chiming in. Let's go ahead and see if we can remember all 4 parts. That's right. So we've got the mental status, the cranial nerves, the sensory, and the motor. And so if you kind of just refresh your memory each time, you can kind of keep track of where you are doing the neurological exam, because for sure the neurological exam is the biggest part of this pass-off. So let's go ahead and take our 10-minute break until 9:45. and then we'll be right back to do the motor section of the neurological exam. Welcome back. So as we continue through the neurological assessment, we've completed the cranial nerves. And if you look at the bottom of your slide here, this is where you can see the link to be able to see the video that we just showed. Okay, so the third part of the neurological assessment is to check motor ability. And so once again, with motor ability, what we want to do is take a look at the patient overall. How are they doing? When they walk into the room and sit down on the bedside or in the chair or on the clinic table, you know, what do we see? Do we see any limps? Do we see any obvious deformities? Do we see that they have muscle tone? Is there muscle wasting? Do they have any involuntary movements, twitches, these types of things? And what does their overall strength appear to be? So in your baseline assessment, you remember we checked strength by checking the grips, where we gripped their hands, and we did the dorsal flexion back and forth against resistance on the feet. And so that is just the overall general assessment of their motor function. Then we have the cerebellar function test. Now these are kind of fun tests because the cerebellum is responsible for balance and coordination. And so these are really the drunk tests that you can see police officers doing at the side of the road to determine if somebody is impaired. So one reason for cerebellar tests not working well is that the person is impaired with some type of substance, but it could also be secondary to a stroke, it could be secondary to a head injury, it could be secondary to a number of other neurological problems that may occur for a person. So we are going to do the balance tests and then the coordination tests. And the first balance test that I want to demonstrate for you is the Romberg test. This is a very classic test that is used very frequently to determine if a person can maintain their balance. And so I have a little video clip to show you what that looks like. Oops. All right, the wrong one. Okay, so you can see that's quite a simple test, but it gives a lot of information. And to do it correctly, the person has to have their feet standing together, as was demonstrated in the film clip. And typically we do it with the eyes open and then again with the eyes closed. We're watching for that swaying. Do they start to lose their balance? People with peripheral neuropathies that are severe will often not be able to feel their feet well underneath them, and they can sway and have balance problems. People with inner ear problems might have a balance problem, or other neurological kinds of problems. So you can see this is a very valuable test. In order to do it correctly, you actually have to watch the patient for 45 to 60 seconds to determine if they have balance or not, because sometimes they start out balanced and then they start to sway and start to lose their balance. Because they have the potential of falling, we're going to want to do a couple of safety things to make sure that they don't fall while we're doing this test. One of the common things is to have the person stand with their back against a wall, and then the physician or the nurse is standing right next to them. So if they begin to sway, the wall is back there to kind of help them position themselves. If they start to sway, they often move their feet to catch their balance, and then you're right there to kind of steady them as well. If you're really concerned about balance, you may want to have them do it right in front of a chair. So if they start to lose their balance, you can kind of assist them in sitting down rather than allowing them to fall. So this is an important safety consideration when doing the Romberg test, a very common test that is done. Running the heels down the opposite shin is also another kind of test that can be done. If the person is standing when we do this test, it is a way of checking for balance and coordination. If they're in bed when they're doing the test, so they're lying down and they're running one heel down the shin of their leg, that's really checking for the ability to coordinate on either side. Coordination tests are kind of the fun tests that we sometimes see people doing at the roadside, where a person might be standing in the middle of the road, or we have them in the examiner's office. They're standing and we have them touch their finger to their nose. So bring their finger in and touch their nose. We do it with their eyes open and again with their eyes closed. One of the ways that children like to have this checked is where the examiner is going to move their finger around in space, and the child is going to touch their nose and then touch the examiner's finger, and then touch their nose and touch the examiner's finger. And of course, the examiner has been moving their fingers, so the person has to move where they're touching when they touch the examiner's finger. Kids think this is a great game, and it really demonstrates whether or not they have coordination. Rapid alternating hand movement is done by actually having them rapidly alternate their hands back and forth, one at a time. Usually the surface they're doing this on is their thighs. They're sitting on the exam table and they're flipping their hand back and forth as quickly as they can on their thigh. Everything with a neurological exam is always done one side of the body and then the other side of the body. Because remember that we have that decussation that occurs in the medulla. And so information from one side of the brain is really controlling the other side of the body. About 80% of that information is controlled on the opposite side of the body. And so we don't ever want to cross midpoint when we're checking neurological exams. And I'll bring that up again when we're doing some of the sensory tests. So very important to do that. For example, when you do the trigeminal cranial nerve, and remember you have the light cotton swab, you're touching on the forehead, the cheek, and the chin, you would never go like this and touch across the forehead. That would make it impossible for the person to distinguish what they felt. If they say, do you feel this? They would say yes, but did they feel it because they felt the right side or did they feel the left side? You don't know. So that's why you have to touch one side and then touch the other side. One side and then the other side. That principle of not crossing midline in neurological exams is true for all neurological exams. So again, you have the little YouTube connection here at the bottom of the video. Okay, so neurological assessment for motor function continues by doing deep tendon reflexes. And so I have a little film clip here to show you how to do the deep tendon reflexes. So let me get that started for you right now. Okay, so again, that gives you an example of each of the reflexes. And because you don't have access to the reflex hammers during your practice today, this is one of the skills that the nurse that you're passing off with will help you with during your pass off. But we would want you to know the names of the deep tendon reflexes, the approximate location you should be attempting to get them at before you come to the pass off on Thursday or Friday. Okay, so we've done 3 of our 4 parts of the neurological exam. We had mental status exam, cranial nerves, motor function, and now sensory function. So with the sensory function, we're starting with the spinal thalamic tracts first. And as we talk about the spinal thalamic tract, this really is an indication of determining if the sensory portion of the spinal column is working. And we're checking the 3 areas of the spinal thalamic tract: the lateral spinal thalamic tract, the ventral spinal thalamic tract, and the posterior column. Now, there are 2 tests for the lateral spinal thalamic tract: the superficial pain and the temperature test. If a person responds to the temperature test, then the pain test would be intact, or vice versa. Ventral spinal thalamic tract is crude touch, and the posterior column is superficial light touch, vibration, and proprioception. So once again, on those 3, if you've got one of the 3, you've got them all, because it shows that the spinal column tract is working in that particular area. So for this one too, I want to give you a little bit of instruction, and then I have a little video clip to show you on the temperature one here, on what that would look like to do. Okay, so now that you've seen it demonstrated, let me just give some clarifying points of things to keep in mind. So on the lateral spinal thalamic tract, he used the pin, the safety pin, to determine the sense of pain. We aren't going to have you do that in your pass off. We are going to have you do the temperature one. And notice the way he did the temperature one. In your pass off, because we have them readily available in the class, let me grab this so you can see what I'm talking about. Oops, I thought I had one in the room, but I don't. We have the tuning fork, and the tuning fork has, the base of the tuning fork is straight and it's quite cold. And the back of your finger is warm by comparison. So those are the things we use for temperature differentiation in the lab. However, in practice, and you'll find this when you do it in the lab, some of you have cold hands. So it's not a very good temperature discretion between those two. So in practice, we often do what was demonstrated in this video. which is to get test tubes that are the same size. Fill one with very warm water, not hot enough to burn, and one with cold water. And then you have them determine whether they feel hot or whether they feel cold. Crude touch is simply touching the person. So touching them on their arm in the various places, and they say now when they feel that they've been touched. And then the posterior column was the light touch, which was demonstrated in this film clip, and vibrations, which is also something that is demonstrated in your video clip that you are practicing for your pass-off. Proprioception is also demonstrated in your video clip that you need for your pass-off. So in your pass-off, you are going to demonstrate all of these tests except the superficial pain test, so that we know that you know how to do them. And so again, if a physician does them or a practitioner does them, you can explain it to the patient, and they, if you weren't the person who actually did the test. Okay, the second part of sensory is the parietal lobe. So you remember that in the brain you have a parietal lobe and you have the motor cortex, and that they work together to communicate so that the sensory information comes in and then triggers the motor response going out. The parietal lobe is responsible for interpreting all that sensory information coming into the brain. And so there are a couple of tests we can do to determine if the parietal lobe is functioning appropriately. And that would be things like stereoagnosis and gravesthesia. Can the person recognize when something small has been put in their hand? So you have them close their eyes, and this is something that is true for all sensory tests, including the sensory test about the spinal column a moment ago. Because they're a sensory test, the person must close their eyes. Otherwise, you don't know if you're checking sensory or vision. So for example, if I put a dime in somebody's hand and they can see me put it in their hand, and I say, tell me what that is, well, they could have told you because they saw the dime. So you have to have them close their eyes. Close their eyes, and then when they close their eyes, you put a dime in their hand or some object in their hand that they're going to recognize. They can feel it all around with that given hand, but they can't cross over midline by trying to feel it with the other hand. It must be done from one side to the other. And then hopefully they'll be able to say, this is a dime, or this is a nickel, or this is a paper clip, or this is a key, whatever you have used for them to feel in that hand. And then of course you do the opposite side of the body as well. That's stereoagnosis. Gravesthesia is when you have them, again, close their eyes and you draw in their hand a letter or a number. And you do tell them what it's going to be. This is going to be a letter, and since their hand is out like this letter is going to be facing you, and then you drew it facing them so that they could recognize that it was a 2. This is going to be a letter would have been, an F or something else. And then a number perhaps for the other one, and you say that's facing me. So if you're standing here, it'd be facing me, and it would be a number 7. I know my letters and numbers, really, I do, on most days. So the point is that you give them the direction that you're facing so they know how to interpret it. They close their eyes, and you do one hand at a time. Okay. So we did the 4 parts of the neurological assessment: mental status, cranial nerves, motor function, and sensory. The last part of the neurological assessment is done specifically, it's a specialty test done for people who have come in for a head injury. And it kind of repeats some of the things that were done in the comprehensive neurological assessment. However, it is a specialty test that is ordered by physicians, and you need to recognize what the physician means when they say this person needs a neuro check or a neurological check. And often they'll order the neurological check every 2 hours or every hour, depending how concerned they are. And when they say a neuro check, this is exactly what they want you to do, not more and not less. This is what a neuro check is, and it's done for people who have a head injury. So for example, if we have an athlete out on the football field and they get hit really hard, they ring the bell, and we're concerned that they have a concussion. And yet we're also concerned they might have a more serious complication, maybe a head bleed or something else, or perhaps they've had a motor vehicle accident or some other kind of head trauma, and they've come in for observation. And initially, their neurological exam has checked out. We've done that comprehensive exam on them. Everything looks okay. But some of our head injuries don't show up until time has passed. And when Vicki starts talking to you next week, she's going to talk to you about some of the brain bleeds that can occur. And some of them actually take a little while to show up, sometimes days and sometimes weeks to show up. And so we would be doing a neuro check to kind of watch this person to make sure that they're not getting one of these more serious complications over time. So the neuro check consists of checking for level of consciousness. So level of consciousness means, is the person awake and alert? A person with a poor level of consciousness is somebody who looks like they're on drugs, but they're not. So for example, how many of you have cared for people who are recovering from surgery? They've gone in for surgery and they're recovering and starting to wake up from the general anesthesia. Have you seen people waking up from general anesthesia? Yeah. So if you're waking up from general anesthesia, you wake up, you're kind of groggy, you're kind of slow to respond. You do answer the questions, things are kind of slow, but you're just not really alert and awake. So the best level of consciousness is alert and awake. And then there are lowering levels of consciousness where the person appears to be more sleepy, less responsive, it takes them more time to respond. Then they could actually become obtunded and go into a full coma. So checking for level of consciousness is the first thing we do with a neuro check. And what we expect to see is that the person will be alert and awake, and they'll respond to their name. You know, how are you doing today? And if they're asleep and you touch them, they should wake up. That would be alert and awake. That's what we expect to see. Now I want you to star and highlight and put in big red, whatever helps you remember this. If a person has a head injury, the most important thing to be monitoring is the level of consciousness. Even if we think it's just a concussion, because a change in level of consciousness is the most sensitive indicator that something more serious than a concussion is going on, that we have something more traumatic that's happened to the brain, and that we need to intervene very, very quickly. So for example, I had a friend who followed a nurse on a night shift. She was the morning shift, and it was a new grad on the night shift who had a patient who'd had a head injury that was in the hospital for observation. So the order of a neuro check every 2 hours had been requested. And the nurse did it. Went in, did this full neuro assessment on him, but noticed that the patient just seemed so tired. And so as they went through the night, they got more and more tired. It was more difficult to wake them up. They did wake up, they did respond, they did answer questions, but they just seemed really out of it and seemed harder and harder for them to wake up as the night progressed. Unfortunately, this new graduate did not realize that meant a change in level of consciousness, and is a very serious and significant sign of a significant head injury going on, something really scary going on. So the new grad didn't want to wake up the doctor in the middle of the night, and so she reported it off to my friend in the morning, who of course immediately called the doctor, because that is the ominous sign you're looking for. And as soon as there's a change in level of consciousness, you switch from neuro checks, which is what we're teaching you right here, to doing the Glasgow Coma Scale, because they're now headed into the path of doing a Glasgow Coma Scale. Yes, exactly. You might think that. So how do we tell the difference? It is quite apparent. So Kaylee has asked, people are tired. It's hard when they wake up. The difference is that you can't get them awake well. So for example, if you wake me up and I'm very, very tired, it may take me maybe even a minute or so of the nurse talking, turning on the lights, sitting me up and saying, how are you doing? I need to look in your eyes to see that they're okay. I need to take your vital signs. You're doing this whole neural check on them, so you're going to have to wake them up. And as you do this, if somebody's just tired, their neurological status starts to wake up more and more and more. A person with a change in level of consciousness doesn't, because it's an actual neurological problem. It isn't just tiredness. And so a person who's been aroused from a deep sleep, you keep stimulating them, they keep waking up. The person with the head injury is not responding. They're not changing to that full awake state that you would expect if you've been pestered in the middle of the night. So that's the ominous sign, is that they're not waking up like they should, even though it's the middle of the night. So good question. Thank you for asking that. If you are at all worried, you should call and be on the safe side, because this is the most sensitive indicator that something bad is happening. You're also checking their vital signs, blood pressure, pulse, and respiration, so that helps to wake them up. You're going to flash a light in their eyes to check for their pupillary response, check their hand grips and their extremity dorsal flexion, but you don't have to do all of the muscles, just the two peripheral ones. And determine if they can sense touch. So you're going to just do crude touch. You're going to touch them in various places. Can you feel me now? And ask them if they have any pain. So this is the typical neuro check that's done every 2 hours. And if it all checks out, we let them go back to sleep for another 2 hours, and we check them again in 2 hours. If anything doesn't check out, especially the level of consciousness, it's a call to the physician right away. The change in vital signs, the change in pupillary response, and some of these other changes happen after the change in level of consciousness. So if you're getting a grouping of these symptoms, even more is going wrong than the initial change in level of consciousness. So if in doubt, the great thing about being a new nurse is that if you're working on a unit, you can ask a more experienced nurse to help you make that decision if you're not quite sure. But if you're in doubt, the safe thing to do is to call. And it's actually, once you see these things, they are distinctly different. And it doesn't seem, it's quite apparent to you once you've seen things. So like so many things with experience, once you've seen it, it's like, oh, that's what people are talking about. Oh, that's what they mean. And it will be apparent to you after you've seen it once, what we're talking about. Good question. Thank you for asking that. So a neuro check is done on somebody who is in for observation following a head trauma. They don't have any evidence of a serious trauma at the time we start observing them, but we're observing them over time in case they develop a problem. And that's what this test is for. So this is something you are just going to, after you've done the comprehensive neuro assessment on your partner, we'll just stop and tell the instructor. So if a patient has a head injury and is in for observation, I would do a neuro check, and you will simply regurgitate this information in your pass-off and tell us what the neuro check is, so that we know you know what belongs in a neuro check. Any questions on any part of the neuro exam? Or anything that we've talked about so far? Okay, so now we're going to go along with our head to toe. And the next thing we're going to be talking about is the integumentary assessment. So this you did as part of your baseline assessment. So this is nothing new. You're going to be looking at color, moisture, temperature, texture, turgor, checking for that tenting, seeing if there's any edema. And remember, we can have two kinds of edema. We can have systemic edema, and we can just edema where it all swells up like you've had an ankle injury and it's just edematous, or you can have pitting edema where you push down on the ankle or the foot and you leave your thumbprint or your fingerprint in their foot, and it leaves an indentation. It takes a little while to reflush back out to the normal surface. That's that's pitting edema. Pitting edema is usually associated with heart failure or some type of fluid overload problem in the body. The non-pitting edema is usually associated with some type of an injury to a given area of the body. Does anybody know what dependent edema means? If I use the word dependent edema to describe something, what am I talking about? That's a thought. Dependent actually means dependent is code for gravity. So if you have dependent edema, you're getting edema wherever gravity is. So many of you have cared for elderly people, and where is their edema most often? Yeah, it's in their feet and then moves up their legs. What if this person is on bed rest and never sits up or rarely sits up? Where would the dependent edema be? Where would gravity take it? Yes, into the bottom, exactly. So the sacral area. And that's where you need to look for it, because that's where it will be. Anytime the word dependent is used, it's code for gravity. So you've heard of dependent loops of urine in the tubing of the Foley catheter. That means the tubing has fallen off, coiling on the bed, and it's now looping off the bed, and the urine that's caught in the loop is in the dependent loop of the urinary bag tubing. And so the word dependent should mean to you gravity when we're talking about assessment information. And then, of course, there can be the various lesions. So when you're doing the integumentary system, both with the baseline and with the full assessment, you don't do it in one spot. You do it as you go along. So when you looked at their face, you looked at their color, and you looked at, did they have any moisture? Are they sweating? You looked at their arms when you were assessing their arms. When you remove their gown to do their lung assessment and their heart assessment, you look at the chest to see if there are any integumentary problems. Are there any lesions of any kind? When you look at their back, you look at the skin. When you look at their buttocks, you look at the skin. So the integumentary system is kind of incorporated as we go along. And so when you do your pass-off, you'll want to point that out, that I'm paying attention to the skin as I go along. Now, when we talk about skin, we're talking about looking for lesions as well. And we know that we can have lesions that are primary lesions, meaning that they arise directly from the skin, or you have secondary lesions which are superimposed on the primary lesions. Now, for your pass-off, you do not need to know the names of the lesions, but you will need them for your quiz and your test in the integumentary unit of this Nursing 1050. So I don't know if this was explained, so I'll do it really quickly now so it will make sense to you. But Nursing 1050 is going to be taught in systems. You're going to be taught neurological, and then you're going to be taught sensory, and then you're going to be taught integumentary. It's going to go in this same order of this pass-off. You are going to learn and do this pass-off and demonstrate it this week. And then as you go through the semester, when you get to the heart and lungs, you're going to have a quiz on the assessment of the heart and lungs. And on your unit exams, you'll have questions about the assessment of the heart and lungs. The same for the abdomen, the same for the sensory, the same for the neurological. There's a method in our madness for all of this repetition. It is known that if you present something at least 3 times, you really understand it very well. So your first time with this full assessment information is this week as part of the pass-off. And then as you go through each unit this semester, you'll be given a quiz on the assessment, and the assessment information will show up again on the unit exam. So you will have seen the assessment information 3 times intentionally, so that by the time you graduate, you guys are good. You know your assessment, and you know what normal findings are, and you know what kinds of abnormal findings you should be looking for. This is really one of the strengths of our program. When we have our graduates go out and work, we get a lot of feedback from the community saying how good they are at recognizing, identifying, and solving patient problems. We can't identify a patient problem if you don't assess it and if you don't know what's normal and what's abnormal to find. And so that's why we're giving so much attention to this assessment information in this semester and why it gets reinforced 3 times as you go along. So your pass-off this week will be to look, and you can just simply say, and I'm looking for skin lesions. But in your quiz for the integumentary system assessment quiz and in your unit exam, you will be asked to talk about these various skin lesions and what they mean and what they look like, etc. So I've embedded, just for your information, to kind of remind you from your fundamentals class, the various kinds of skin lesions. Those below the skin surface, fluid-filled cavity skin lesions, palpable ones, and non-palpable ones. Again, this information will be part of your integumentary unit in a couple of weeks. And for your pass-off, you simply need to say, I'm looking for skin lesions. We're especially looking for the ones that are a little bit scary. We know ecchymosis means a bruise. Petechiae, we see that a lot in our elderly people. Cherryangiomas, phytoangiomas, and then the suspicious melanoma, the thing that we're worried about most for cancers. There are 3 types of skin cancer: squamous cell, basal cell, and melanomas. Melanomas are the ones that are potentially life-threatening. And this describes that: variegated color, irregular border, irregular surface, enlarging size, and persistent bleeding. That picture is a pretty good picture of what one would look like. So those you as a nurse would really want to notice on your patients, and they would be worthy of the phone call to the doctor right away, probably not in the middle of the night, but within, the very next time you see the doctor, the next time that they round, a very timely phone call if you suspect a melanoma. If you see other signs of other skin cancers, they're so slow growing that it's usually okay to just tell the doctor the next time you encounter them, later that day or tomorrow or whenever it may be. Okay, part of looking at the integumentary system is looking at the nails. So again, I want everybody to pull out their nails, take a look at the nails, and tell me what you can learn about yourself by looking at your nails. And if yours are pretty uneventful, tell me some things you might have seen on some of your patients' nails that gave you some information about them. You could check the capillary refill, discoloration, brittle nails, a ripple in the growth, vitamin deficiencies, that's some of the things it could represent. Clubbing, again, and clubbing is one that only happens with a chronic hypoxic state, but that's definitely something we're looking for. And then, dirty nails. Do they care for the nails? Do they have a thick or fungus infection growing on their nails? This isn't actually uncommon. How many of you have seen fungus infections, especially in toenails of elderly people? Biting. I'm glad that you brought that up. I was looking for that one. You can tell, does this person bite their nails all the time? Are they anxious? Is this something they do to kind of cope? And yes, beautifully painted nails. Who goes the extra mile and has time? Probably not nursing school, right? Has time to get their nails painted and have them match and be coordinated, etc. And of course, when we're in clinical, we can't do the acrylic nails, but it's kind of fun to do between clinicals. So we can learn a lot from the nail assessment. So that's part of what we're going to look like. The integumentary system with the nails, again, this is just showing you some pictures of the various nails of what's right and wrong. And you can look at these in your PowerPoint more carefully so that you can kind of see what we're looking for abnormalities. But once again, just like the skin lesions, in the pass-off this week, you're simply going to be stating, I would be looking at the nails, I'd be looking to see if they're clean, if they're well trimmed, if there's any fungus, if there's any kind of clubbing or spooning. But you don't have to describe what clubbing and spooning are. You're just going to tell me what it is you're going to be assessing the nails for. Okay, now we're on to the head. So with the head, we're actually going to be, again, looking, we always inspect, right? And we're going to also be feeling the head for, and the scalp. So when we look at the hair, we're going to look for the texture and luster. Is there absence of hair? Do they have alopecia? Is there normal male pattern baldness that exists? What's the distribution of the hair? Is it thin? Is it thick? Is it clean? Is it dirty? Is it well managed? Is it not? That type of thing. When we look at the scalp itself, we're actually going to start looking at the hair. So again, you're going to be going kind of looking between the hair and behind the ears, and you're going to be looking for any little critters and in the back of the head. And you're going to be looking for at the scalp to see if there's any kind of lesions or problems. Now, what's really interesting is, you can have various kinds of dermatological problems that happen on the scalp. I had a former student once who actually developed shingles underneath her hair on one side of her head. It was discovered by her beautician. She knew that she had pain and problems, but couldn't figure out what it was. And it turned out to be shingles, very painful. And so very challenging for her there. So all kinds of things can happen, and we're watching for those. We're also being careful to wear gloves when we do an assessment of the scalp because critters could be there, right? Including lice. And so that's what you have a picture of here. We have a little picture of a lice here crawling on a hair shaft. And this is a picture of a nit. A nit is an egg of the lice. And they often do show up behind the ear and along the back of the scalp line in the back of the neck. And so, of course, now we have various kinds of shampoos that can be used to get rid of nits and lice, which is good. And but I always like to bring this up because it's kind of an interesting little fact. Back in the olden days, before they had these products, the way people got rid of lice and nits was to take a fine-tooth comb and go in there and literally look at every hair shaft and flick off the little nit egg to try to get it off the hair shaft, to try to cure this infestation of lice. That's why we call people who pick at small things nitpickers. I just thought that was kind of a fun little fact to know. Okay, face assessment. So now we're moving on to the face. And once again, the first thing we do is look at the overall appearance. We've got this cute little baby in front of us. We see that the features are symmetrical, that the structures are placed in the appropriate place, that her eyes are line up appropriately with the ears, that what is their expression at rest. And so we're doing an overall visual inspection of the face. Then we're going to do the eyes. The eyes, we're going to look at the outside of the eyes. We're looking for redness, yellowness that might be jaundice. Do they have excessive tearing? Do they have dry eye and complain of blurred vision? Do they have bulging eyes that might be associated with a thyroid problem? Do they have drooping eyelids that might be a part of a neurological problem? So we're going to do an overall assessment of the eyes and determine if there are any problems there. Now we're going to do the visual acuity test. Now the visual acuity test was actually part of the cranial nerves. And so when you get to the eyes, you will just simply say, I did this when I did the cranial nerves. We won't have you do it twice. They overlap. The reason this is important is because if somebody has an eye problem, it could be because of a local eye problem, or it can be because of a neurological problem, right? Because the brain's in charge of everything. So you have to make the distinction based on the whole assessment and the history to make a determination. Do I have a visual problem because I've had a stroke in the occipital lobe, or do I have a visual problem because I have a local eye problem? So I want to give you just a little bit more explanation than the video did about how to do a Snellen eye chart test. And you will be doing this as part of your pass-off. Typically, when nurses do a Snellen eye chart test in practice, it's in a clinic or an ER, or is as a school nurse where you're doing the vision tests on everybody all at once, all these children in the gym. And I want to just point out to you that, can you see my little red mark show up on this when I'm pointing to things? Oh, good. Okay. So I want you to notice that the E, which is the biggest thing, is 2200. And that normal vision, which we all know is 2020, is line 8 here. But notice that all of these start with 20, and then they have a number after them. The 20 means that the patient who's being tested is standing exactly 20 feet from the Snellen eye chart. That's critical. That's what that 20 means. You are not using the standing Snellen eye chart correctly unless they're exactly 20 feet from the chart. Now, when we go to do the test, we're going to do it one eye at a time, and we're going to have the person start by telling us what line they think they can read clearly. Then they have that cover the eye, and we have them with a card, we point to one letter at a time. So the person would say F, L, E, Z, P, O, D. Now I did them out of order because if you're doing it for children, which you often are as a school nurse, and a child knows they can't see well, these very smart kids memorize the lines before they get to their eye test. So if you do it randomly out of order, they can't memorize it and you can get an accurate visual test on them. If you get everything on the line, you come down to the next line and you see how many of them they can get right. As soon as one is missed, that becomes their line. And so let's suppose that on this line I missed one. I would claim that my right eye was 20, 20, minus 1. In other words, I didn't get it perfectly. If I miss more than half of the line, I can't count this line as my vision. So let's suppose I did the 20/20 line, but I missed 5 of them. Well, half of this line is 4. So I can't count this line. I'd have to go back up and test this one right above. And if I get it completely correct, it's just 20/25 without any misses. Or I might have gotten 20/25 minus 2, whatever it may be. Now, notice the key is half the line. Half the line is different as we go up here. Half this line is 3. Half this line is 2. So that half the line, and you can't count it. If they miss more than half the line, you can't count it, and you need to go one more up the scale. Once they they get most of the line correct, you can count that as their level of reading. Now let's suppose that I got 20/20 minus 1. Once you've missed one, you do not descend further down to see if they could have gotten this line with more than half the line correct. If you've missed one, it becomes the line. Does that make sense? Does anybody have any questions with that part of it? Okay, hopefully you don't. Let me tell you how to interpret these lines. So 20/20 we all know is normal vision. So that means the person taking this test is standing 20 feet from the Snellen eye chart, and they see this line number 8. If I'm a person with 20/50 vision, you can tell my vision isn't as good. And what that means is that the person is standing, the patient is standing at 20 feet, but they see what a normal person would have been able to see at 50 feet. So a person with normal vision could have stood 50 feet away and still seen this line. Now there are numbers, it's not shown on this scale, but it also goes true here. This would have been 20/15. So if a person is standing at 20 feet and can read the 20/15 line, it means that they can see at 20 feet what most people with normal vision would have had to step closer to 15 feet to be able to see that line. Give me some feedback and let me know if this makes sense to people. Do you understand how to interpret the... Okay, good. If you don't, please, as always, I'm happy to answer questions. And part of the chat this afternoon in lab, feel free to ask your questions or send me a text and email, and I'd be happy to clarify anything that you desire to have clarified. There are 2 ways that you can be considered legally blind. One is that, so that's another point. When you use the Snellen eye chart, you do allow them to use their glasses or contacts. So some of you out there might use glasses or contacts and realize that if you don't have them in, you can't see this chart standing 20 feet away. So you are not legally blind because when you have your glasses or contacts in, you can see the chart, hopefully somewhere close to 20/20 vision. So we always use the corrective lens when checking the Snellen eye chart. To be considered legally blind, with your glasses or eye contacts, you still can't see this big U. It's pretty bad, isn't it? That would make you legally blind. A second way to be legally blind is to have poor peripheral vision. So in the video that we showed you for checking peripheral vision, we had you stand behind the person and you bring your hand down one at a time and you see where the person can see the vision and from side to side. So I hope you guys have seen this and this is making sense to you. And what happens if somebody has really poor peripheral vision is they will not be able to see your finger until you start bringing it close in this way or bringing it close in this way. Most of us have peripheral vision that's almost, 180 degrees here. But if you have poor peripheral vision, it's like you're getting tunnel vision. So it would mean you've got tiny, tiny tunnel vision and that you can't see anything except straight ahead. So if you have really, really poor tunnel vision, then that's another way of being legally blind. Any questions about the Snellen eye chart? Okay, the peripheral vision test is what I was just showing you a moment ago, where you have you come in one finger at a time and compare to see how far out they can see. And so that you did when you did your cranial nerve. So all you have to say is that you've already done them. You've already done the extraocular motor. This is what I mean by the X instead of the H. Can you see an H right here too? Is the same. It's just two ways of drawing the same thing. And then PERLA, which you did as part of your cranial nerves. And then you're going to use the ophthalmoscope to look inside the eyes. So when you start going through the face, you're going to do each system of the face, but the eyes, you've already done some of the tests for the eyes. So you're going to look at the external eye, and then you're going to say, I did all my other eye tests during my cranial nerves. And now I need to take the ophthalmoscope and look in the person's eyes, and then we'd have you look in the people's eyes at that time. Any questions about how to organize yourself through the eye exam and what things mean? Okay, this is a good break time. Let's take our break again until 10:45, and then we'll come back and we'll keep plugging along. Okay, welcome back. So now we're going to do the ear assessment. And the ear assessment, again, is going to start by just looking at the external ear. Placement, size, shape, symmetry. Does anybody have any guesses about what's gone on in the picture in front of you? What do you think is happening there? Yeah, it's an infection from a pierced earring. You can see the little hole right there where there is a, they tried to pierce the ear and it got infected. So yeah, we're looking for any kind of abnormalities on the outside, and we're checking for mastoid tenderness as well. So just like the eyes, when you get to the ears, you're going to see that many of the tests repeat what you did for cranial nerves. And this is the case with the gross hearing tests as well. So all you have to do is say, I've already done the hearing test with the cranial nerves. Then you're going to take the opportunity to look inside the ear. And you're going to be using the otoscope to do that. And you will receive some instruction during the pass-off on how to use the audioscope, since you didn't have the opportunity to do that before. So we're going to be looking for cerumen, which is earwax, any lesions, foreign bodies, these kids, they can get all kinds of things in their ears, discharge, and then we're going to be looking at the eardrum itself. It should have a natural grayish, shiny, translucent appearance, and there's going to be a light reflex if the eardrum is intact. What that really is that the light you're shining into the ear reflexes off the intact eardrum, and you can see a little triangle at the bottom that really looks like somebody's got a little flashlight in there pointing back at you. So you can kind of see that light reflex. It's kind of fun. Now we're going to move on to the nose. So once again, we're going to look at the external nose, and I want you again to turn on your mirrors and on your phone or a mirror in your room and take a look at your nose and tell me if you have a deviated septum or a bump on your nose, or if there's anything else that makes the external nose look like it's asymmetrical or that there's any deformity there. And obviously, as we're looking at people for their obstruction or their nose, we'd want to know their history that went along with it. So I can see a few people typing there. We'll find out all kinds of things about our fellow students here. Yeah, 3 surgeries. No more deviated septum. Wow, that's quite an ordeal to have to go through 3 of them to get it to work. And then, of course, if we did have a history, if we did have a deformity, we'd want to know the history. Did you have a trauma of the face? Did you, were you born this way? What is the reason for this? And yes, and that's a good point that you bring up, Megan, is that we would want to know the snoring history, because that helps us to know if there's any kind of nasal problem as well. So that's an important thing for us to get in our history as well. We're also going to want to look at the internal structures. So we can do this with a source of a pen light. So you want a pen light, you want to just shine the light up the nose so that you can see inside the nose. And we're looking for the mucosa, the color, any lesions or swelling or bleeding. And we're also going to be paying attention to if they have an infection, what kind of discharge do they have? Is it yellowish or is it green? That would indicate an infection of some type. If it's a clear discharge, that favors an allergy as the reason for it. Next, we're going to assess the sinuses. And there are 2 ways that can be done. You can just push on the area of the sinuses, ethmoid and maxillary, or you can tap the frontal, the ethmoid, and the maxillary on both sides of the face. Now, if anybody's had sinusitis, you know that that really hurts. So I want you to take a moment at home and just do that. Either press firmly or tap in the area of the sinuses. And you can see, you can feel it, but it's not especially tender. If a person has sinusitis, they don't like you doing this. This hurts. It's very, very tender for somebody who's got sinusitis. Now we're going to move on to the lips and the mouth. And we're going to look at the external lips. Are they cracked? Are there any lesions? Do you have a cold sore? Is it discolored in any way? Do you have a bluish hue to it for any reason? Are you getting hypoxic? Are you very cold? What is it that we're seeing when we look at the lips? Then we're going to look inside the mouth. So to look inside the mouth, you need a source of light. You need your pen light because it's dark in there. You can't really see anything unless you light it up with your pen light. There will be a tongue blade available for you to use, so you can use it to look at all of the structures inside the mouth. You're going to look at the teeth. Are there any cavities? Is it in good condition? Is it in poor condition? You're going to look at the tongue. Is it dried up and with lots of furrows, meaning that you're dehydrated? Is it plump and red, meaning that maybe you're in overhydrated state? So we're going to be looking at the position of the tongue. We can check for taste, but you already did that as part of your cranial nerve, so you can just say that. We're going to look at the back of the throat with the uvula, and you did that as part of your cranial nerves as well. So you don't have to check a gag reflex twice. But we are going to ask you, does your partner have tonsils or don't they have tonsils? We want you to truly look inside their mouth and see if you can figure out what's going on. Okay, so before we move on to the neck, I want to give you your hint for how to memorize this. So for the neurological exam, you memorized that there were 4 parts. They were, I told you I'd tell you 100 times during this, they were mental status, cranial nerves, motor function, sensory function, and then of course you did the neurocheck as part of that. For the face, the easiest way to memorize this is simply look at your partner and assess everything you see in front of you. You see they had a head of hair, you see they have eyes, you see they have a nose, you see they have a mouth, you see they have ears. One of the things that we will be doing during the pass-off is we will insist that you complete a system before you move to the next. So for example, if you start doing the eyes and you've looked at the external eyes and you told me that the cranial nerves did the other things, and then you try to move to the ears, I might say to you something about Don't you want to see if they have any problems inside the eye? And you go, oh, yes, that's right. I need to look in with the ophthalmoscope. So this is a big pass off. It is not uncommon for people to have a little bit of prompting. But the key is that if you know it well, it's an occasional reminder. So don't be flustered if you have an occasional reminder, because lots of people need an occasional reminder. We expect that. This is a big pass off. But we can tell the difference between people who need an occasional reminder and somebody who really hasn't prepared for this pass off. So we will help you stay on track by making you complete one system before you go to the next. And in the neural system, we'll make you finish the mental status before we let you start the cranial nerves. We'll finish the cranial nerves before we let you go to motor, etc. So this will help you stay on track and help us all kind of be on the same page during the pass off. Now, the order of this pass off is really been done because of the ease of doing the pass off. In practice, you just pull out the tests you want when you want them and when it's appropriate. So this order is for the order of the pass off. Okay, so now let's move on to the neck. And while we're doing this, I want you just kind of to do it to yourself. Let's do it together as we're checking the assessment of the lymph nodes on the neck. So as you're doing this, we're going to be pushing on the various chains of the lymph nodes to see if we feel any enlargements. And in order to do that, you want to use your fingers, and you want to use the pads of your fingers, and you want to make a circular motion. It's not okay to just tap. I think your example in the film, she just taps and announces the name. But if you were really assessing a person, you'd actually have to feel it. So I'd like you to do that in your pass-off. Kind of do that circular motion as you're feeling it and naming it to make sure you've got it. So let's do them together. Kind of wake yourself up, do these with me. So we've got our preauricular, which is in front of the ear here. We have the parotid, which is at the base of the ear. And we've got the postauricular, which is behind the ear. And then we have the occipital, which, no surprise, is right back here at the back of the neck, right at the base of the skull. So we had preauricular, parotid, postauricular, occipital. Now the tonsillary are the ones right in this little triangle between the jaw and in the neck. These are the ones we all go for when we're sick. It's like, oh, I wonder if I have strep throat. And we stick our fingers right in that spot to see if we have an enlarged lymph node, and we push around in that circular motion. That's the tonsillary site. Then we have our two columns, the posterior and anterior cervical lymph nodes. So this is in reference to these muscles down your neck here. And you're going to touch in front of the muscle for the anterior and in the back of the muscle for the posterior. And it's a chain, so it's a length of movement. It's not a particular spot. So let's do the anterior first. So find that muscle in your neck, and you're going to push just in the anterior portion all the way down to the clavicle. And then in the posterior portion of that neck muscle, all the way down to the clavicle. Now let's do the ones that are part of the chin. So we have the submaxillary and the submental, which is at the tip under your right here. And then submaxillary, again, we're pushing in all those areas. And then supraclavicular, which is right above the clavicle. So let's go ahead, and we've got a little video here that shows you these. Let's let you look at this real quickly so that you can see these well. Okay, so that really allowed you to see that you really have to push around to be able to see this, and that any enlarged lymph node is considered abnormal. Now, sometimes we'll know the story behind the abnormal enlarged lymph node and consider it benign. So, for example, when I was in nursing school, I had a tooth abscess that drained into one of my lymph nodes. And of course, you can never get out of nursing school for anything, right? I had to get clinical. It took me a little while to get to the dentist to solve the problem. And I, to this day, have a tiny little enlarged lymph node in my neck. But I know the story. It has no pain. It's never grown over time, but it is an abnormality because you should not have enlarged lymph nodes. Now, we are concerned when we have enlarged lymph nodes that are painless and seem to be sticking to things. So, for example, enlarging lymph nodes that adhere to the surrounding muscles and do not move around easily. That favors some type of a lymph cancer and needs to be reported immediately. If you have enlarged tender lymph nodes, especially if it goes along with the signs and symptoms of a cold, then that's to be expected, or a tooth abscess or some other infection that explains why that lymph node is enlarged, then you would expect it to go away after the infection has resided or has resolved. The other part of the neck that we're going to look at is we're going to look at the trachea to make sure that it's in alignment, that the neck angles are symmetrical, and that the trapeze sternocleidomastoid muscle has strength. That's what we did when we did this earlier to see if it had strength. And then we're going to look at the vessels in the neck. And to demonstrate this, I want to show just a little bit of a video that shows you what we're talking about here. So there are two vessels in the neck that we're paying attention to. One is the carotid, so I want you just one finger at a time, find your carotid. It's just right here at the side of your neck, and you should be able to feel a strong pulse. Got your carotid artery there. Then we're going to be looking for neck veins, and they're a little bit further back. Neck veins have waves. They don't have pulsations, and that is a distinct difference. So I want you to see what I mean here by showing this little video. Okay, so the distinctions I want you to get there is that if you're over the carotid artery, you could see a pulsation. It looks more distinct and in its pulsation, and you can feel it. So that makes it an artery. If it's a vein, it's more of a wave that's pulsating through the area and not so pinpointed. And when you feel on it, you cannot feel a pulsation. You cannot count anything because it's a vein and they're very stretchy and they don't carry a heartbeat that can be distinguished through that vessel. So when you do your neck exam, you will be laying the person down, turning their head to the side, and distinguishing for us their vein and their artery. Okay, now we're on to the heart. So this is the good news, folks. From this point forward, the vast majority of it is a repeat of your baseline assessment. So let's quickly go through these, which, as I said, is a repeat of your baseline assessment. And so you're kind of in the home run here because you've got most of this down. So with the heart, of course, we're going to expose the chest and we're going to inspect to see if we see any heaves. So this is an inspection. So that means that we would see the chest wall rise would be a heave. We can also sometimes see the point of maximum impulse, especially in younger people and thinner people. Over the aortic site, you can sometimes see a pinpoint pulsation, and that would be a visual inspection of the PMI. And then, of course, if they have telemetry in place, we'd want to note that as well. The second thing we're going to do is we're going to palpate. So palpate means touch. And I'm going to put my hand over the chest wall on the right, on the left side, and I'm going to see if I can feel a lift. So if my hand elevates with each beat of the heart, that would be a lift. Now I want you to put your hand over your right side of your heart right now. And hopefully all of you are normal and you cannot feel a lift. And for that matter, you probably can't feel the pulse unless you're young and thin, and you might be able to feel something over the PMI. A thrill is when you have your hand over the chest and you feel turbulence coming through the chest wall. This would reflect a very bad murmur that is so turbulent that it's actually vibrating through the chest wall. And that vibration is called a thrill. So we've inspected, we palpated. Now we're going to auscultate. We're going to check the rate and rhythm, checking for S1 and S2, and we're going to check at our various sites. So once again, you have to refresh your memory on this. The aortic site is the second intercostal on the right sternal border. The pulmonic is the second intercostal on the left sternal border. Obviously, we're checking the heart on the left side. I'm kind of wondering if I said right a minute ago. Somebody can tell me if I said that backwards. My visual image in front of me is the opposite of me, and I might have said it backwards because of that. So obviously, the heart is on the left side, and it is something that is where we're going to be putting it, right? So we're going to put the pulmonic on the second intercostal left sternal border, then the third intercostal left sternal border. The tricuspid is the fourth or fifth intercostal left sternal border, and the mitral or PMI is the fifth intercostal midclavicular site. So, yes, so I apologize for saying right. Like I say, my visual image flips in front of me, and of course the heart is on the left. And so we're going to be doing the palpation, the inspection, and all of those things on the left. Thank you. Thank you for giving me the pass card there. Okay, so then the rest of it is the vascular assessment. The vascular assessment is to inspect and look for lesions. We're also checking for palpation, temperature, capillary refill, pulse, amplitude, and for bruits. So we have a little bit of a review here with a video clip to help you see this. And so let's go ahead and plug that in to demonstrate this. Okay, so that just demonstrated how to check each of the pulses, the peripheral pulses, and there are times that we need to check each of those. Thank goodness we don't have to check for the popliteal very often. However, the most common situation where we have to do that is a below the knee amputation. It becomes the most peripheral pulse, and we want to make sure that the circulation is good there. So you have access to that video as well to help review that if you have a desire to. Okay, so we did our peripheral pulses, and now we're going to move on to the respiratory system. So once again, we're going to be inspecting, and we're going to be looking at the chest wall for color, if there's a barrel chest, if they're using accessory muscles for breathing, if they have unequal chest expansion or any abnormal breath sounds, and if they have, muscle development problems. Sometimes there might be some muscle atrophy. Some of our muscular dystrophy situations may create some problems with this. Respiratory assessment with thoracic palpation. So this is where we're going to be touching the person. We're going to be checking to see if they have any tender areas, if they have moisture, if there's a temperature change, if there are many masses present. We're going to check chest expansion and vibration or phrenitis. So once again, we have a little bit of a video here to help us review some of those things. So let me insert that so you can see it being done. I think these kinds of things are best seen. Okay, and then of course this particular film clip shows some percussion and some other things that can be done with the lungs as well. All percussion, we haven't attempted to teach you percussion as a PN or a first-year nursing student, but for those of you that desire to go on to become a nurse practitioner, this will become part of your assessment as well. Okay, part of your pass-off is to do exactly what you did in the baseline assessment. to go ahead and define the normal breath sounds, where they're located and what they mean, and to define the adventitious breath sounds, or the breath sounds that are added to normal breath sounds, superimposed on normal breath sounds, and what they mean. And also to be able to describe and demonstrate voice transmission tests and when they're used and what they mean. So we have a little film clip that's going to review all of those with you. And what I like about this film clip is that it's also not only defining it for you, but it's also letting you hear what we're talking about, which we are going to start reinforcing this semester. So when you do the respiratory system, you're going to have learning activities that require you to listen to more and more breath sounds, because it's one thing to define them in a lab, and it's another thing to be able to recognize what you're hearing when you're listening to a patient. So this film clip is going to start introducing you to what things really sound like. Okay, so I like that video because it's very concise and it summarizes the important points well. I like the visuals and I like the fact that it actually allows you to hear what we're talking about. So I think that's definitely one worthy of repeating and seeing numerous times until you really feel like you understand what each of these things are. So now we're leaving the respiratory system and we're moving on to the abdominal system. So once again, we start with inspection. Remember, the abdominal system is the only one that requires you to do your assessment in a particular order. Does anybody remember what that order is? The technique orders. So right, so you observe, so you inspect, and then you're going to go ahead and auscultate, and then we've taught you palpate, but for those of you that are becoming nurse practitioner, there are 4 assessment techniques. Percussion, and on the abdomen, percussion comes before palpation. So the order is inspection, auscultation, percussion, palpation. Inspection, auscultation, percussion, palpation. Because palpation's the very last, because it would disrupt the other sounds. So for inspection, we're taking a look. We're seeing if anybody has any abdominal distension. And when we talk about abdominal distension, it can be distended due to gas or air, or it can be distended due to water, as in the case of ascites. And it can be a slight distension, or it can be a large distension. It can be a soft distension versus a firm distension. So the best way to kind of think about this is water balloons. If you fill a balloon with air, you can fill it partially up. It is distended. It looks distended, but when you push on it, it's soft. Or you could fill the balloon completely with air, and when you push on it, it is tight or firm. The same can be done with a water balloon. If you fill the water balloon partly full, you can definitely see the distension, but it's when you push on it, it's soft. And when you lay it on the table surface, the water kind of disperses to the side a little bit instead of remaining taut. If you fill it up completely with water, then it's very taut and full. It looks distended, and when you push on it, it's firm. So those are the description words that we use when we talk about abdominal distension. And we have in mind when we're describing it, is it distended with air or is it distended with water? We're also looking for any integumentary things that we can see on the abdomen: masses, scars, pulsations, umbilicus. The place you're looking for a pulsation is right at the upper part of the mid-abdomen, where you can sometimes see a little pulsation coming from the heart in the aorta right there. That's normal in a person who's small or a child or a very thin person. But as people get older and as they get heavier, we can no longer see that pulsation. That is the place we would listen for a bruit. A bruit happens when there is turbulence in an artery, which means that there's some kind of pathology present. Most arteries are silent when you listen to them. So if you hear something, that's a problem. We're also listening to the 4 quadrants for vowel sounds, and I just described listening for a bruit. And then we're going to palpate the abdomen with light palpation and deep palpation. So again, let's take a little quick video clip showing this and reminding us how this is done. Okay, so you can see that she did the abdominal assessment very much like we expect it to be done when you are doing your pass off. Rebound tenderness, as you recall, is when we push firmly in a spot where we suspect some inflammation in the bowel. It's a deep palpation. You push firmly in the spot, kind of let the tissue adjust, and then quickly lift your hand off the abdomen. And the tissue, as it rebounds into place, if it's inflamed at all, will cause a lot of pain. This is usually to help check for appendicitis, but it can be for any kind of inflammation in the abdomen. If we do suspect appendicitis, it's usually wise to let the physician check for the rebound tenderness. You can see it'd be very unwise if the nurse checked for rebound tenderness and then the intern checked for it and then the physician checked for it and then the surgeon checked for it. Let's see if we can get the appendix to rupture before we get them to surgery, right? So we want the person who's going to make the diagnosis be the one that checks for the rebound tenderness. When you're doing the abdominal assessment, remember you're going to be asking your questions and you're going to be determining if they're constipated, if they have diarrhea, if they have black tarry stools. Somebody tell me what black tarry stools mean. Yeah, it's a GI bleed, and specifically an upper GI bleed, meaning that they're bleeding in the stomach or the duodenum, or sometimes if you have esophageal varices that's been bleeding and they've swallowed a lot of blood. Sometimes you can see that if somebody has a profound nosebleed and they swallow a lot of blood. So an upper GI bleed will come through as black and tarry stool, and it usually is very stinky as well. Bloody stools mean that the bleed is in the lower GI, because if you can actually see the red blood, then it's happening down in the lower bowel. It might be a polyp, it might be diverticulitis, it might be that you have a hemorrhoid. And then clay-colored stool, your stools are brown because you have bile in them. So if you have a clay-colored stool, kind of like the grayish color of cement, then that means that something's going on with the getting bile to your stools. So something with the gallbladder, either you're not making it or there's an obstruction or something of this nature. So we're going to be assessing the bowel movements and in learning what the various things we see may mean. We're also going to be doing a genital urinary assessment where we're going to be checking the urinary system. We're going to either look at the urine. Interesting. Thank you, Megan, for that question. If someone has their gallbladder removed, do they have clay-colored stools? The answer is no. The gallbladder is merely a storage unit. So you actually make your bile in the liver. It gets released and then stored in the gallbladder. And then when you eat a high-fat meal, your gallbladder contracts and releases more bile into the GI tract to help you emulsify that fat. That's why when you have gallstones that are blocking the gallbladder from releasing that, eating a high-fat meal causes pain because the gallbladder is trying to release more bile and it can't get through the obstruction. So after you have your gallbladder removed, it just goes directly from the liver into the GI tract and your stools are still brown. Good question. Okay, so we're talking about the urinary system then, and it is characteristics. So your usual questions that you did in your baseline assessment. CVA tenderness is something that you weren't taught in your baseline assessment that you need to be aware of and is demonstrated in the student video, where she puts her hand on the person's back because your kidneys are stored retro in the abdomen, in the back of the abdomen. So you put your hand on the back and you thump your hand lightly. And if there's tenderness because there's inflammation or infection, then that would indicate that something's going on with your kidney. You do not have to tap hard. Matter of fact, you see many people just go like this. It's very tender. And so just a light tap will let you know if they're uncomfortable with CVA tenderness. The last section here is the musculoskeletal assessment. So this kind of overlaps a little bit with the motor function section in the neurological assessment. And it's kind of just picking up some of the things that we didn't do in the neurological assessment. So once again, it's talking about bilateral symmetry of the muscles. What's their posture? Do they have any spine curvatures? Do they have scoliosis? Do they have a gait problem? Are they using a walker, a cane, a crutch? Are they missing any digits? Do they have edema? So it's just a general appearance of things musculoskeletal. Then we're going to check for strength, and this overlaps with what you did during the motor section in the cranial nerve, checking the hand grips and the dorsal flexion. And so you can just say I did that in the in the motor section of the neurological assessment. And then in the film, it shows you how to check each muscle group bilaterally. And so that's the time that you can do that muscle strength test as well. Range of motion is repeated as part of this pass-off to remind you of it. So nothing new about this. And so just refresh your memory because you will be doing it as part of your pass-off. So the neck, flex, extend, hyperextend, lateral flexion, lateral rotation, run through them all and refresh your memory about them. Neurovascular check. As part of the pass-off, we are going to say to you at this point, you have a patient who has perhaps a shoulder injury or an elbow injury or a wrist injury or an ankle injury, a knee injury, a hip surgery. And we would expect you to know that a neurovascular check is done for orthopedic patients and that it consists of these three parts. And I know that when you first learn this, you learn some little tricks to help you remember each of them under circulation. So under circulation on the very periphery of the injured area, so supposing that my left shoulder is injured, and so I'm doing the periphery, because if you've got everything working down here, then it's working the whole way up your arm to the area of the injury. So that's why this neurovascular check is always done in the most peripheral part of the extremity. Circulation included pulse, capillary refill, checking for edema, color, and temperature. Motor was to see if the extremity would flex and extend. Can you move it? Sometimes people say, can you wiggle your fingers? But we really want to see the whole flexing of the movement to see that it's working well. And then sensory, this is a sensory test, folks. So what do you have to tell the patient before you do it? There's an instruction for all sensory tests. Close their eyes, exactly. So close your eyes and I'm going to touch your extremity. And remember that you touch their extremity on the outside of the thumb, in the web space, and on the other side of the pinky here. If this was the foot, it would be the same. The outer of the greater toe in the web space between the great toe and the next toe, and on the other side of the foot. The reason you touch in those places is because you have three major nerves that innervate the hands and the feet. You touch in those spaces and they can feel you, then you've checked all three nerves. The follow-up question is, do you feel any numbness and tingling? Because if a person has numbness and tingling, it means something's wrong with the nerve. Now, sometimes beginning students think that means the person has a circulation problem. I want to make this very clear. If you have numbness and tingling, you have nerve damage. Now, one of the reasons you might have nerve damage is if you have poor circulation to the nerves. So if circulation caused you to have poor blood flow to the nerves, it would start damaging the nerve, and the nerve would have sensations of paresthesia or numbness and tingling. But you can have nerve damage without a circulation problem. So for example, a number of years ago, the person who gave me my flu shot went far too high in my arm, and it must have hit a nerve because I had pain down my arm for several days. I wondered if I was going to have to do something about it. It took a lot of Motrin. It finally cleared up. So there was no circulation problem, but I had numbness, tingling, and pain because my nerve had been damaged. So I just want you to realize that numbness and tingling is associated with the nerve. It could be secondary to circulation, but it also could be secondary to some other reason that the nerve was damaged. Now, this is another mistake that sometimes students make. You need to recognize the difference between a neurocheck and a neurovascular check. When will a doctor order a neuro check? What kind of patient will be given the order for a neuro check? Yeah, a TBI, a head injury of some kind. What kind of patient is going to get a neurovascular check? Exactly, orthopedic patients. So you've twisted your ankle, you've had surgery, you've broken a limb, any kind of orthopedic problem, right? And with your orthopedic check, it's always the most distal part of the extremity, because if you've got it working down here in the tips of your hand or foot, it's working all the way up the extremity. So that's an important consideration. This is what happens in our 1050 class. You guys get it straight for this pass-up, but I'm always concerned that on the final exam, there's a handful of students who are mixing those two tests up. They are two distinctly different tests for two distinct reasons. And even though there are some overlap of what you do in these tests, in other words, you do check sensory, sense of touch in both tests, but it isn't the same thing. The tests are not the same. And they're not more or less than what's said here. So please really make a distinction in your mind what a neurocheck is, what the parts of the neurocheck is, and what it's used for. What a neurovascular check is, what the parts of the neurovascular check is, and what it's used for. Very important to keep those straight, because the doctor just expects you to know it. When they say do neurochecks, they expect that set of tests. They say a neurovascular check, they want this orthopedic check. And all of it, not more, not less. Okay, very good. The last thing I want to comment on before we take our break is the story behind breast self-exam and testicular self-exam. In the past, we used to have you educate your partner to do a breast self-exam or a testicular self-exam. We no longer do that. The reason for that is breast self-exam was taught for many years to women in all kinds of settings and was highly utilized. But as they've done studies on breast self-exam, they have found that it's not yielding the results that were hoped for, meaning that there hasn't been a decrease in the number of deaths due to breast cancer because people were doing breast self-exams. And sometimes it was leading to false, for tests that, in other words, the woman felt that they felt a lump, people got nervous, they did more extensive tests or biopsies for a lot of benign things. So it's kind of fallen from favor. Having said that, how many, just throw in there if you have had your OBGYN teach you or tell you to do breast self-exam recently? Just throw it in if you've had that experience. Yes. Any others? Yes, me. Not me. Yeah. So this is the story. We have three national groups telling physicians whether or not they should do breast self-exam. Primary care physicians have been told by their body not to do it anymore. Those that study statistics about everything and are encouraging all kinds of self-tests are no longer encouraging it. But the OBGYN practice is still claiming there's an indication for it. So if you're being taught this, it's almost always taught by your OBGYN. And their logic is that it may not be changing the death rate, but if you catch it early, it might be changing the quality of life for a person. I don't know, I kind of suspect it's a matter of time and the OBGYN people will no longer encourage it as well. But we'll wait and see. So what I'm saying is that this is in flux. This is not our decision as a nurse to make. If your physician wants you to teach breast self-exam, we've given you the instructions here. It's in your fundamental book. You would need to learn it and know how to teach it. But many places are no longer teaching it. Testicular self-exam is still being taught because testicular cancer is found between the ages of 15 and 40. This is an important test. However, the men in our class, will you just chip in and tell me if anybody has ever taught you testicular self-exam? If any medical person has taught you, a doctor or some type of thing. Yeah. So Mark has. Any of our other men in there ever been taught? Oh, well, good. Several of you have. So we're doing a little better with that. It's often hit and miss when I ask this question of our male students. Some have been, some have not been. One of the challenges of getting this self-exam taught to men is not that it's not a valuable exam, it is. But men, unlike women, don't usually routinely come in for primary care visits if they're a healthy male. When you see them, it's usually in the ER because they've been in some kind of an accident, or it's a pre-sport physical, or it's some other kind of thing. And it's not always on the radar screen of the person who they went to for whatever specialty thing they were there to see. So we are encouraging men to be taught testicular self-exam because it is still considered important for them to be watching for that. Unfortunately, getting to the younger people who are the primary people who need to know about this is a little difficult because they don't routinely come to healthcare the way women do to their OBGYN, especially during childbearing years. So one of the things that's really a key thing for us to make sure men know is that they should report if one testicle feels heavier or looks bigger than the other testicle. That is an ominous sign, especially that heaviness. They didn't have it and now they do have it. That is something that should be checked out right away. Okay, so that actually is our information on the comprehensive health assessment. And so there is a learning activity that goes with today's information. And rather than make you check back in with me after lunch, I'm going to give you class time for the learning activity, and I'll turn it on as soon as we're finished talking here. Right now it's set for 12:30, but as soon as I end this class, I'll turn it on. And you will be given time to complete that learning activity. It's part of class time to do that. So I encourage you to do it now or right after your lunch, and take care of it before your lab this afternoon or before you get involved in anything else today. It technically is available until midnight tonight, but it will not be available after that. So you do need to do it during this time that we are giving you to do it. Does anybody have any questions about the comprehensive health assessment? I've really tried to make it visual as best you can online, and to kind of give you hints along the way of the things we're going to be paying attention to when you pass it off for us. Does anybody have any specific questions or clarifications? You're welcome to talk to me if that's faster, just to turn on your mic. Okay, it doesn't look like anybody's making any comments. So now let me just prime you before we take our lunch break about what to expect with the comprehensive health assessment lab. So I'm kind of repeating what I said this morning, but you do need to have a lab practice partner because you will go through it twice during your lab time. And really, we can tell who's practiced and who has not when it comes to the pass-off. This is a high point pass-off that does need to be memorized. And so you're going to really want to put some effort into it. We've intentionally done this the first day and first week of school so that you can concentrate solely on it before you have other class tests and exams and clinical papers, etc. You can give your full attention to preparing for this comprehensive health assessment. The way we'll do the lab is you're going to need your video of the student doing the lab comprehensive pass-off. And you are going to do it in small segments. So you're going to do the neuro through mental status, and you're going to stop and do it on your patient. Then you'll do your cranial nerves, stop and do it on your patients. The motor test, stop and do it on your patient. The sensory test, stop and do it on your patient. The neck, stop it on your patient. You get what I'm saying. So take it in small chunks, stop and do it on your patient. Use your handout to know which tests you need to include and which ones you don't need to worry about. The very first thing you're going to do on your lab is to check in with me in chats. Chats will be on, and I expect to see a check-in and you to tell me the name of the person who is your lab partner who you're practicing with. And once you've done it in that kind of incremented way the first time, asking your questions, figuring things out, then you're going to go head to toe the second time without watching the video and try starting to commit it to memory and to try to get your flow of going through it head to toe. The video, you'll notice, only takes about 35 minutes to complete. You are each given 1 hour to complete the lab. To complete the pass-off. So when you come in with your partner, you're going to bring your bed sheet from home, you're going to be wearing your uniform, and you're going to bring your supplies that you need. We will have the ophthalmoscope, the otoscope, we'll have cotton balls, we'll have cotton tip swabs, we'll have a tongue depressor, we'll have that kind of thing. But you'll need your pen light and your stethoscope and those types of things to be brought with you. It only takes, good question, you don't choose your partner exactly. You've been set up at a pass-off time. And so I believe 10 of you are coming into the building at a time, and you will be wearing all of your PPE gear because we're going to be in close proximity. And this is done live with your instructor sitting in the room. So out of those 10 in that given time, we don't dictate who you line up with. You can grab who's available. But please be helpful to each other so everybody has a partner they can pass off with. If you're assigned at the same time, you can choose within the people you've been assigned at the same time with. So when you come in, you're being given a whole hour to do what the student demonstrator did in 35 minutes. So what I'm saying is you have plenty of time to do it. And we really do expect you to complete it within that hour. As we said, there can be some prompting, but if we have to prompt you a lot, or if you're really leaving out portions and we really realize you're not understanding something, we can ask you to redo it in parts. So for example, cranial nerves can be a real challenge, and they're often new to people. Many of these other parts of the pass-off are just a repeat of baseline or quite straightforward. Look at the face and just remember what you need to remember about the face. So if you stumble through your cranial nerves, but everything else looks really good, we would just ask you to redo your cranial nerves. Now you'll lose points for not having done the cranial nerves correctly the first time through. Your points are earned on your first attempt. And even though you're asked to redo a portion of it, that doesn't earn you more points back. So you want to do your best on your first attempt that you can and come in prepared. That's why we're giving you so much lab practice time. People who utilize that well really feel well prepared and just have to commit things to memory between now and their actual pass-off. So if you have to do redo, we'll reschedule that and have you come in next week to finish up your redo. If you are doing it, but it's clear that you don't know it well, and you are really slow in doing it, and you get to that hour, we're going to cut you off at that hour. So let's suppose you only made it to the abdomen and you haven't finished the musculoskeletal and you haven't finished range of motion. You would lose the points for the things you haven't completed. And we would have to have you come back and we'd negotiate with you what parts of redo you would need to do. It's unusual for people to take that long. An hour is usually very adequate for people, and they don't feel rushed to accomplish it. If you know it well, an hour is plenty of time. If you don't know it well, it can take you a long time. So my point is, really study this. Take advantage of the fact that we're giving you a lot of practice time today or tomorrow. Really make an effort to commit it to memory. And actually, the vast majority of you will sail through this. We're just always so amazed and impressed at how well people do. And so have confidence. If you know it, you know it. If you need a little reminder here or there, don't let that derail you in your pass-off. Everybody needs a little reminder here or there, and that's okay. We can really tell who have practiced and know it and who have really not got it down. So please practice before you come. Any questions about the assessment or the pass-up? For TACE, you bring a sour taste for the back of the tongue and a sweet taste for the front, honey or sugar. Any other questions that I can answer for the group? And do you feel like you know what's expected? The same, people bring something, sometimes they bring scents they have at home, a lavender or peppermint. Cooking smells are often good. Some people bring coffee beans, those are easy to smell. Things of that nature work well. Any other questions? Now, your chance to get all your questions answered, especially as you go through in the lab, that might be when you start having questions about exactly how this will work. And that's the time to catch me in the lab. Chat me your question and I will answer it. I will be in my office watching the chat line so that I can answer any questions. Are you going to check in at the beginning of your lab? I expect to see lots of answers. So yes, the answer is you all have to check in the lab. Primarily, I would like you to check in on the day I'm expecting to see you. If you have a problem getting a partner today or tomorrow and would like to switch days, that can be done, but I need you to communicate that to me in advance. Send me an email so I would know what to expect. Very good, thank you. I'm always glad to see people are still out there. It's a bit hard to talk to the screen, as you guys know from being on the other end and not having the same interaction. So I always appreciate when you respond to my questions and give me some feedback. Is there anything else I need to do to help this be clear? Have confidence, you guys are smart, you've got this down. We really have people do very well on this, and you will as well. So just give it the practice time and you'll do great. And I'll see those of you checking in today at 1:30. You'll check into the lab through the chat room, and tomorrow's group will check in tomorrow at 1:30. And I also want you to check out of the lab. So when you're done, I expect to see a little chat from you saying that you're done and that you don't have any questions or you're done. And I do have just a couple last minute questions, whatever the case may be. But so you're going to check in and check out of the lab so I know what's going on. And when you check in, give me the name of your partner. Okay, you guys are great. I'm excited for you. I'm excited that you've made it through summer and that you're going full head this fall. And we're very excited because when we get in the new building, we hope to see you in person. Won't that be fun? We're really looking forward to that, to have you back with us at the school. So stay well. And let me know if you have any questions or if there's anything else you need from me. Don't forget the learning assignment that's part of this class. And we'll see those of you doing lab today at 1:30 on chat. Thanks, you guys.